we'll move on to the next session of sort of new frontiers in interventional cardiology. And as you know, we have Dr. Horst Sievert, one of the world's experts in different areas of intervention of structural heart disease, with a lot of focus on stroke and as well as other structural heart disease that's left atrial appendage.
Okay, thank you very much, and thanks to the organizers for inviting me to give this talk about acute stroke intervention. So let me start with some background information. Stroke is really the second leading cause of death worldwide. We have about 4 million deaths due to stroke annual per year, and that is, as you can see, number 2 after coronary artery disease. 90% of all strokes are ischemic, and when you look at the different etiology of these ischemic strokes, you can see that the majority of these strokes are principally suitable for a catheter intervention. The background of catheter intervention or any intervention in acute stroke is the so-called penumbra, which is an area between the dead tissue and the healthy tissue in the brain, and this is the area which can benefit from opening the occluded vessel either by IV lysis or by catheter techniques. And this penumbra, this diffusion-perfusion mismatch is actually present in almost all cases initially, and even the percentage obviously goes down, but even after a longer time of period, up to 24 hours, some of these patients have a penumbra, which means they have brain which can be salvaged by an intervention. So what's the current status of acute stroke management in 2013? Is it in most places where we have been with acute MI management 20 years ago, which means there's not enough recognition in the community, which means late onset to call time, bad transport systems for acute stroke patients, which means patients arrive too late in the hospital, slow assessment in the hospital, which means delayed transfer to the cath lab. Devices are not perfect, we are not good enough, and that's why results are not good enough yet. What is required for acute stroke interventions? Well, actually time is brain, which means the best way to gain time is to educate future patients about early signs of TIA and stroke and to speed up the transfer to the hospital. If for some reason it takes 5 hours from symptom onset to arrival in the hospital, you cannot run an acute stroke program. And there are very sophisticated systems like this one, not in our center, but in another German city, where they have actually CT scan in the transportation system integrated. That's probably not necessary, but certainly transport systems are very important to run an acute stroke program, whereas in many other places, not only in India, but even more maybe in Germany, it's more like this here. And in the hospitals, restructure or bypass the emergency room, bring the patient immediately to the CT scanner, and then in the CT scanner you can do the CT scan, but also you can obtain the history, you can perform the lab test, and you can even start IV lysis if that is indicated. So let's talk a little bit about IV lysis. This is a meta-analysis of all these studies, and you can see that IV lysis is effective. But you can also see that obviously the longer it takes, the odds ratio of that therapy is decreasing, which is because the penumbra is decreasing. So the trialists looked at that and said, well, great results, IV lysis works. But at the end of the day, in large strokes, IV lysis is not a convincing strategy. Imagine you are admitted to an emergency room with a big stroke. You are hemiplegic, you cannot speak, you are unconscious, and let's assume, obviously only for the purpose of this lecture, that you can still hear. If you have a big stroke, you cannot, but let's assume you can hear for the purpose of this lecture. And the ER doctor tells you, well, unlikely that we can help you because you arrived too late. You probably have one of the following contraindications for IV lysis, which may be hemorrhage on CT, possible subarachnoidal hemorrhage, blood glucose below 3 or above 20, blood pressure above 185, suspected or known pregnancy, active bleeding from any side, active pancreatitis, anemia, thrombocytopenia, epileptic seizure at stroke onset, very severe stroke, anticoagulation therapy, recent stroke, or 2 weeks surgery or trauma. So because of all these contraindications, the chance that you can get IV lysis is only about 5%, and that's in the literature. 5% is your chance that you can get IV lysis when you arrive with a stroke in the hospital. And he also will tell you, honestly, you will not miss too much, because with your big vessel occlusion, the chance to get it open would be only 10%, even if we give you IV lysis. By the way, did I mention that after successful opening by IV lysis, there is a 20% risk of re-occlusion? So despite your major stroke, for the purpose of this presentation, you are still able to calculate your chance to get the vessel open. So the chance to get IV lysis is 5%. The chance to get the vessel open by IV lysis, if you can get it, is 10%. Out of 5% is 0.5%. The risk of re-occlusion is 20%. So overall, your chance to get the vessel open is only 0.4%. Now you know why patients with a major stroke prefer to stay unconscious. They just don't want to calculate their chances to get the vessel open. You may think, let's quickly move to another emergency room. But it is not difficult to end up in a hospital where they start with 1% IV lysis instead of 5% IV lysis. And then the chance to get the vessel open is only 0.08%. So yes, IV lysis trials have been positive, but after 3 months, 50 to 60% of patients were either dependent or dead, and that's not really called a success. So why is intra-arterial therapy better? Angiography allows localization of the occlusion. Drug can be given directly to target area. Higher dose can be given without systemic effect. Mechanical thrombectomy devices can be used, and you can visualize immediate results when you do intra-arterial therapy. Well, but how to recanalize mechanically? Over the last 5-10 years, a number of different devices have been developed, and really the breakthrough of all these devices had been the stent retriever. What is the stent retriever? It looks like a self-expanding 19-hole stent connected to a wire. So you cross the occlusion with a wire, then you advance a microcatheter across the thrombus, then you expose the self-expanding stent retriever, and finally you pull it back out of the intracranial vessel into the guiding catheter. So is that feasible? Yes, it is, and I will show you an example. This is a 37-year-old male patient admitted with an acute left hemispheric stroke. Symptoms started an hour ago. Patient is hemiplegic and unconscious. So left carotid artery shows normal findings, so there's no extracranial disease in this patient, but left middle cerebral artery is completely occluded. For some reason in this patient also the right middle cerebral artery and the right anterior cerebral artery are filled, but you can see the occlusion of the middle cerebral artery where that arrow points to. So a microcatheter is advanced into that area. A whisper wire, which is well known for you from coronary procedures, is crossed, and you cross the lesion. Here you can see the stent retriever, the solitaire in place. You can see over here, the mouse doesn't work. Okay, so you can see here the distal end of the stent retriever. The stent retriever by itself cannot be seen, but here is the proximal end of this system. So now after 5 minutes, we leave the stent retriever there for a few minutes in order to allow the stent struts to go through the through the thrombus. You can see already some flow. And thereafter, the stent retriever is pulled out and the clot comes out together with the stent, and you can see the result after reopening this vessel, and this is the aspirate which could be taken out. So the outcome in this patient, awake on the table, discharged 5 days later with minor residual symptoms, and otherwise this patient would have been severely dependent for the rest of his life. I have no idea who put that slide into my presentation, but it's about our stroke course in October in London. So all these are good news, but there are no good news without bad news. And unfortunately, this year, 3 trials had been published which showed negative result, a negative outcome of intra-arterial therapy. I will not go into details because, in my opinion, all these trials are outdated. So why are all these trials had been negative? Well, most of these patients did not have large vessel occlusion. Treatment delays, for example, in the IMS-3 study, from admission into the hospital to groin access, 2 hours, that was the mean delay. Groin access to intra-arterial therapy, 44 minutes. And some studies did not combine with IV lysis, and they also used outdated devices. Stent retrievers were rarely used. Why? Because they had not been available at the time when these trials started. So which patients are the best patients? When IV TPA is contraindicated, when IV TPA fails or is likely to fail, like in large vessel occlusion where the opening rate is only 10%. Then very symptomatic patients with an NIH stroke scale score of 8 or higher, and those patients who have a mismatch, which means a mismatch between symptoms and CT findings, or perfusion and diffusion if you do advanced imaging techniques, and also proximal artery occlusion. Thank you very much for your attention.
Horst, we have just a couple minutes for questions, and you talked about I just want to ask, just out of personal, you talked about all the barriers to setting up a program, and it sounds like even if as the has to be a commitment from the hospital and all the staff to get the patient there. Who do you think is going to be doing these procedures? And we're talking about people, I mean, and should they, if it's a cardiologist doing it, should it be someone that's done, is it the same, it's a different skill set? Is it transferable? Should they have done, 5,000 angioplasties before they start engaging in cerebral disease? What is the progression and who do you think will be doing it in the future?
Well, actually, obviously, most often these procedures are done by interventional neuroradiologists at the current time. But when you look at the number of practicing interventional neuroradiologists and compare this with the number of strokes, it would be impossible that they can handle all the strokes who need treatment. So the question comes up, should cardiologists do this? And I think absolutely yes, for a number of reasons. First of all, the technique is not very much different from the techniques we use for the coronaries. So getting access to the carotid artery is not difficult. We are using wires the same as the neurointerventionist people do. Microcatheters are not much different from PCI balloons. So technically it's not really difficult. And also we have all the system already established. All the emergency system is available. We are on call anyway. So I think we should really take over to do this, not independently from INR people, but in collaboration with them.
Yes.
I just have a comment. A contraindication of some sort, however you define it. For mechanical removal of the clot, I am really not sure that it is relevant. I know it has always been a tradition for thrombolytic therapy, for mechanical removal, because the blood pressure that you see after stroke is really a reactive increase in blood pressure, Cushing's reflex.
Absolutely.
So that's something that many people actually are barred because of the reactive hypertension, which is very common. Just a comment.
Yeah, that's absolutely true. Hypertension may be an indication for IV lysis, but it's certainly, and maybe for intra-arterial lysis, but certainly not for mechanical recanalization. And that is the beauty of these techniques, that all the contraindications for lysis are not present for, are not valid for mechanical recanalization.